But thanks for Kelly and Debbie for spearheading this. It's great to be talking to this group, and I really appreciate the opportunity. So I will dig right in, and definitely stop me along the way if you have questions. And I've been given the permission to ask questions too, which I may do that, because I certainly don't really know what I'm doing, as is evidenced by the inability to advance slides. But now I know the trick. The financial disclosures, I think all of these are fairly well, there's transparent, they're on there. I don't think there's anything that directly impacts what I'm going to say. I don't prescribe opioids. I don't prescribe any drugs for that matter. And most of what my financial disclosures for salary support, and I do have one royalties, but it's for educational content for Rehab Essentials, which delivers material online, and I put together a pain module for them. So hopefully this will kick it off. And it always has to zoom to something. This time it's the desktop. So thank you for entertaining that. That gives a nice background summary. And I'm going to start off by talking about some of my key assumptions in putting this talk together. And the first is that opening crawl was worth a $6 donation. So the way this works is you can send them text and they will do this. And it's kind of a brilliant business model because it's free. But the wait time when I looked at it for the free option was like 380 days. And then they say, we'll put you ahead if you put in a donation. So I was like, I'll try a $6 donation. And I got it in 4 hours. So it's a really genius business model. So that is the first assumption, that was worth a $6 donation. I got a little fixated on it after I guess so I had to make it work. But I think it does provide a nice background, a little bit of where we are and where we'd like to go with that, and obviously in a very familiar way. The other kind of more traditional background is that there's a high prevalence of chronic pain. It's more than a lot of conditions that are viewed are accepted, I should say, as public health problems, more than those combined. And that the largest subset of this chronic pain is from musculoskeletal disorders. Again, that can be quite broadly applied, but including arthritis, but when you lump those all together, they're by far the largest subset of chronic pain. So that means I want that, and that's what I have studied mostly. So all these lessons that I'm talking about will be lessons learned from musculoskeletal pain, which I think is incredibly relevant because of the high prevalence. The impact is really what has been driving the awareness of chronic pain the last 10, 15 years. I think it's now widely recognized as a leading cause of disability, not just in the States, but globally, depending on which global burden of disease top 10 list you're looking at. Typically, headaches and back pain and joint pain and neck pain are in the top 10, depending on how they measure things. Everyone has their cost estimates, which are always astronomical. The Institute of Medicine one is the $635 billion total cost estimate. And then, of course, the ongoing opioid crisis, which is a result of the impact. And the reason I call this the last opioid is I'm going to kind of assume that the opioid crisis is going to be taken care of, and I'll clarify what I mean. And really the challenge is to think kind of what is pain management going to look like. And when I say that, I think, and we've talked about this with colleagues, I think people tend to mush addiction, opioid prescription, and pain management all together. They mush them all together. And what people are really focused on now is opioid prescription. And I think that's actually going to be a relatively easy thing to deal with. And then we're going to be left with addiction and pain management. And I'm here to talk a lot, almost entirely about pain management, because that's what I know. And I'm not going to talk much about addiction, not because I don't think it's unimportant, just because you would not invite me to talk to you about addiction. So the opioid prescription part, I find that I am aligned with the International Association Study of Pain Statement on Opioids. And I think a lot of people are going to rein in their prescribing patterns to follow this in one way or the other. And it's basically to kind of go back to how opioids were thought to be used most effectively probably 20, 30 years ago. Short term, for severe pain, 2 weeks post-operative, yes, definitely. 6 months post-operative, maybe not as much. And then, of course, at the end of life. Where it has gotten a little slippery and where you're going to see the opioid prescriptions reined in, and this has already started in many states, is when it's not as clear as an endpoint for when the opioid use should stop. And this is where non-specific, that lovely but horribly vague term, non-specific chronic pain, that's where the opioid prescription rates have really increased and left some people with more problems than solutions. And it is especially a problem in the US and in Canada. So this is kind of their recommendation is that people are carefully monitored and that instead of it just being pain relief, focus on quality of life. But I really think it's going to come back to that first statement, that there's going to be periods and conditions where short-term use is and should be used, by the way. If I have an elective surgery, I definitely want to have access to opioids. And I would like to think if I was at end of life, I would like to have access to opioids. Luckily, I don't have to make that decision right now. And then the middle will get cleared out. So that's kind of my jumping off point for this talk. And like I said, this really comes from me thinking about unentangling addiction, pain management, and opioids prescription. Does everybody understand why you need to pull those apart? Because a lot of times when people talk about this, I've been in plenty of rooms where people are talking about all three of those at the same time, and you do have to get people to consciously pull them apart because they're very different things. So this is the third assumption, which hopefully I made a case for, that this audience is willing to look a little bit ahead of after the opioid crisis, and my focus will be on pain management because, like I said, you could do much better for someone talking about addiction. So what do we do about it? I had the opportunity to write an op-ed. I guess it's getting a little old now, but I think one of the things that writing this did help me to understand is the system problems. And this is an often used quote that every system is perfectly designed to get the results it gets. So I think we do have to realize that this opioid crisis was, and this pain management kind of hole is a result of the way the system was designed. And I think we have to understand that the system was just doing what it was designed to do, and that was to offer, prescription for pain. And when you look at what options are available, it didn't take too long to see how those two became connected, especially when prescription patterns and, now we know that there was some aggressive marketing going on and, all of those things contributed to this. But remember, the system was in place to have this happen very quickly relative to what some other changes we'd like to see in the healthcare system. So I took this opportunity to think a little bit about, you know, if I could have a wish list of 3 things to change in our healthcare system that might get us to offer more comprehensive or more guideline adherent pain management options. It's these 3 bullets: divorcing the biomedical model, changing delivery approaches and patterns, and then valuing prediction over treatment effects. And of course, I'll go into those a little bit more as we go along. Is everyone on board? How long do you usually leave for questions? Let's see. Okay. Okay. I haven't decided if I'm taking them during it. But obviously I'm asking them during. Yes, so here's finally divorcing the biomedical model, which I am going to link pretty strongly with a diagnosis-based approach. The challenge then would be aligning with biopsychosocial models, which I think tend to be a little more prognostic-based. And here's my short history of imaging in musculoskeletal pain. This story is really well known in the spine. It's going to become really well known in other areas. In fact, already is, and I'll highlight that. But since the spine is where we really learned this lesson, I'm going to give you the short history of spine imaging. And it's like 4 slides. So when I first started practicing as a PT, which was early 90s, imaging was thought to be an important precursor for diagnosis of treatment of back pain. This is when CT and MR were really starting to ramp up and were thought to be a valuable clinical tool. And were thought to drive identification of where pathology may reside, and that you needed to have this in order for the treatment to be effective. Some really clever people started questioning the accuracy of these imaging findings. And they were really clever because what they did is they imaged non-symptomatic people who weren't seeking healthcare, which was now seems kind of, you know, of course we should have thought of that. But when these studies were coming out, it was really eye-opening, especially to the medical field, to image people who weren't seeking care. And guess what? They found that the rates of some of the pathology in people not seeking care and without history of back pain were very, very similar to the rates of people seeking care. And that led to rightfully questioning, well, how accurate then is this spine image that I'm getting on this particular patient? That then, the accuracy was so bad that in some of the guidelines that came out in the early 2000s and late 1990s, routine imaging of back pain was not recommended. This continues to be a struggle for our system to this day, by the way. If you look at imaging use, there are some systems that do this well, and then there's some systems where it still runs rampant and unchecked. What is really interesting is there now is strong enough evidence that suggests imaging is actually harmful. Routine imaging is actually harmful for the individual being diagnosed in treatment with routine back pain. And the reason for that, again, goes back to the accuracy. There are certain age groups that you are much more likely to find pathology, and I'm using air quotes because it's really abnormalities, but there are certain age groups where you are going to find those. And whether or not they are related to the clinical presentation is not known, but they are easy. Again, the system has ways to deliver treatments that are geared toward them. And these are now known in the spine to be as fairly low value procedures, such as injections and certain spinal surgeries. So it's taken about 20, 25 years, but it's gone from being imaging has been recommended, we need to know the diagnosis to treat, to now you're actually, as a person, probably better off if your imaging isn't an early part of your treatment. This is not to say imaging doesn't have a role. This is just to say it shouldn't be at the beginning of the episode. So we have learned in the spine and in other areas that the diagnosis is not, and that is the basis of the biomedical model, by the way, the diagnosis is not the best driver for pain management decisions. And there's some really interesting converging evidence now coming from the knee and the shoulder. There was a really high impact trial in Europe. I think it was subacromial decompression compared to conservative treatments. And guess what? The surgery wasn't better than just doing conservative treatment. It was a non-inferiority type of thing. They've done this in the knee with meniscal surgeries. Meniscal surgery isn't even better than placebo in some, in at least 2 trials. So there is converging evidence that this is not just a spine type of thing. This is a general characteristic of musculoskeletal disorders. And this just reinforces that some of the things that we think are important in making pain management decisions, they're just not as strongly linked to the existing diagnostic methods. I should emphasize that too. And that's the symptom severity, functional status, clinical progression. And there are some very fascinating studies that look at, self-report measures versus imaging. And in almost all of them, the self-report measures tend to be better predictors of outcome than how many millimeters of herniation there are, in an intervertebral disc. So what do we do? What I have done, I've tried to do in some of my research attempts and talking about this is an opportunity to use the biopsychosocial models to better understand the variability that is inherent in pain conditions. I don't think there's anything wrong with the diagnostic techniques, by the way. They are super accurate at identifying the pathology, the abnormality. The problem is they do not account for nearly enough variation to be useful. I mean, that's what it boils down to. And that sometimes is tricky because they're not seeing, it's not that they're inaccurate in seeing what's not there. They're inaccurate in being able to predict what happens or what the clinical presentation is. And this is true for imaging and for the PTs in the audience. It's always fun to pick on ourselves. This is true for a lot of the things that we train our students to do or that we do as part of routine clinical practice, which is pushing on people's spines and measuring range of motion and things like that. So the way to understand variability may not be here. But what is nice in the pain research world, there has been a lot of attempts to frame what might it look, what are the things you have to consider for pain management. And this is a great image from Irene Tracy. It's in a 2007 publication of hers. I use it a lot because I think this boils down, I think, the key elements for understanding what may need to be measured to make decisions in pain management. The other thing I love about this is there's no anatomical specificity. And I think one of the biggest issues, I'm a provider turned into a researcher. And one of the things I think we as providers get biased in our training almost too well is that the knee and the shoulder and the back are different because they are different biomechanically, they're different anatomically. But as a source of pain, they may not differ as much as they do anatomically and biomechanically. And if you think about how care is delivered in an orthopedic surgery department, for example, it's aligned along those anatomical divisions. It's not necessarily aligned in this way. Have you seen this before? It's a really nice, and Irene Tracy is a very well-known neuroimager from the UK. This is, like I said, like 12 years old now, but some of the things she's doing now I don't truly understand. So I assume that that's getting more nuanced and a better understanding. But this to me is kind of a bread and butter. And it highlights, you need to account for the original injury or damage, and that is characterized by peripheral sensitization. This is why I say some of the existing diagnostic tests may not be really helpful because that lumbar image doesn't measure inflammatory responses directly. It doesn't measure some of the biochemical things that are going on. People are getting better at accounting for peripheral sensitization. Then there's this whole idea that pain and nociception are different, which hopefully, does everyone understand that? Nociception is the impulse, that's what is carried, and then pain is how it is expressed and characterized. So when we say nociceptive modulation, that means that original nerve signal can be modulated all along the pathway before it's expressed as pain. And those are measures of central sensitization, which depending on where you are in the pain research field, that's like, the answer to everything, or we've been there and done that. And I'm somewhere in between. I know it's not the answer to everything because we've studied it. If it was, I would have figured it out in the basement at the University of Florida, my postdoc, because I did 2 years quantitative sensory testing every which way and another, and we had so much data, and I learned a lot, but I also learned it's not the be all end all. And then the pain experience, the other thing I like about this is it's pretty clearly indicates that the pain experience beyond the peripheral and central sensitization, which is the bio part for a lot of people, these are the psychosocial components that you need to have. You need to know what the person's mood is. You need to know the context, and you need to know their cognitive set to fully explain the variability that is expressed in pain. And for me, I've used this analogy before and it's helpful, so hopefully it'll be helpful to you. This changes pain from a multiple choice question, like is it A, B, C, or D, to it's more of an essay question. When you look at person's pain experience, it becomes more of an essay question. And I don't think that makes it any more or less real or any more or less objective. I think it just changes the way that you assess it. And you need to have it across a couple of components. And there are models out there, by the way, where people are getting really good at characterizing what they think the potential is for peripheral sensitization, central sensitization, and then combining that with the mood. What we've done most of our research in is looking at central sensitization and comparing it with mood and context. And I can tell you in most of our models, the mood, context, cognitive set tends to be the better predictor, but you can improve it by knowing something about their central sensitization. Where I haven't done as much work is putting in the peripheral sensitization. The people who tend to study peripheral sensitization don't tend to look at all of these, but they're drifting in that direction. So it'll be very interesting to see what this might look like, what an assessment may look like in 5 or 10 years. And I know Bill Maxner, a lot of people, I know he worked here for a very, very, very long time. You know, this is one of the things that's really driving his assessment work in the pain clinic that he does. He gets he's collecting samples so he can get the peripheral sensitization at a very high resolution. They're doing some direct measures of pain sensitivity, and then they're also looking at some of the coping and mood. So he's one of the few that's trying to put this all together. And if it's like the stuff he's done in the past, he'll find some really cool stuff and you know, help informing the field. So that's the challenge and the opportunity in divorcing the biomedical model. What's nice about that is we do have, there's someone to remarry if you need to remarry really quickly, depending on, you know, but there is another model. It's not just saying we're dumping this one. There's actually a model that you can move to that makes sense for pain management.
So Bill's collecting all of the data for each one of these categories.
Yes.
Has he looked to see if someone's doing the visual analog, you know, score 0 to 10 and scoring their pain, how much each of those categories is responsible for their final score?
I think obviously that's something he'll look to. I know in talking to Bill, and I don't collaborate directly with him, but we meet and talk. Bill's also interested in the time, like the density of pain. So he tends to look at the density, which is the intensity over how long you've had it. So I would expect when he looks at these, they will be, the intensity measure will be a component of it, but he'll also look at kind of how long you've had it. Because the problem with just the intensity measure at one point is if you have 10 out of 10 pain for 5 minutes, you know, if I measure that on like a brief pain inventory, that's going to be your representation over the last 24 hours, even though it was only 5 minutes. So some people have questioned that. What Bill, when the last time I talked to him, showed me some of the data they're working on in the clinic, is more using these to develop clusters for people. And they have 3 clusters. The 2 that are, I guess, more the treatable, because one is an adaptive cluster. And adaptive people can still have pain, by the way. There's a distress, which is high on this. And then there's the pain sensitivity, which is high on both of these. And those people tend to have higher pain scores and poorer outcomes and things like that. Does that answer the question?
Yeah.
So the next priority, routinely providing guideline adherent care. And one of the challenges of this is changing the timing of the care. I refer back to the American College of Physicians clinical practice guidelines in 2017. This project came out just in time for the project that Kelly and I ended up working on because we were able to cite it pretty heavily. And this again is for back pain, but this will drift into other areas over the next 5 or 10 years. Given that most patients with acute or subacute low back pain, so we're talking about acute or subacute, improve over time, clinicians and patients should select non-pharmacologic treatment. So that's the guideline recommendation. The rest of it is talking about all the different types of non-pharmacological treatment, which all have equally mediocre evidence supporting their use. But the important part of this guideline is it was one of the first to suggest non-pharmacologic treatment needs to be in the initial episode. So let's look for chronic back pain. Clinicians and patients should initially select non-pharmacologic treatment. So even for the chronic back pain, the initial selection still is recommended to be non-pharmacologic. And just like the other one, there's a lot of, mediocre evidence. You don't know which non-pharmacological treatment is superior. I will fully acknowledge these guidelines are probably driven by risk, right? The risk with non-pharmacological treatments is a lot lower than some of their pharmacological. It's not that they're more effective, but because of the way the system kind of overcorrected for pain, this is viewed as a more palatable way to do pain management. So let's look at what this means. So this is a pain kind of a generic, hopefully it's enough descriptive that it fits its purpose, but it's not to say this is how it's at Duke or UNC or any other place. But we've already talked about how that first contact tends to be a diagnosis. And this is done traditionally by a medical provider, right? Physician. And then we know overwhelmingly when the medical provider is the first provider, there's going to be a drug prescribed. We know that when we look at health services research, we know that when we look at epidemiological research. It really became a problem when those started being also heavily, opioid, narcotic based. And then what happens is after a reassessment period, and that gray, does it show up horribly there? Yeah, it really does. It's not a placebo box. It actually says, so anything non-pharmacological is going to be empty on your screen. In mine, it's a light shade of gray, which I was wondering, is that going to show up? And now I know it's not going to show up. But the point of this is the medical provider, there's some initial treatment, and then the reassessment is, that's when they consider non-pharmacological. Well, you're not doing good initially, we'll try something else. And that's for the provider that is the medical provider that's paying attention. The way the system is really geared is to have care escalation at this point, right? Now, this is where the system is really in tune. Well, if you're on a drug, we're gonna put you on a higher grade drug. If you're on a higher grade drug, you're gonna get an injection. And if the injection didn't work, you're gonna get surgery. So that's why I put care escalation there. And this is not anyone's fault, by the way. I'm picking on medical providers just because they happen to be the gateway to this system. This is what is easiest for them to do. We all agree? It's not necessarily that they are thinking that this is, in the best interest or worst interest. This is just when you're in the day-to-day, this is how the pathways that are established that are easy to follow. So interesting things start to happen when you look at systems that maybe do this a little bit differently. And I've had the opportunity to do a few of these studies. There's enough of them out there now. These are all observational, by the way. And I pick on this one because this was one of the early ones that we did. And it was in the military. The nice thing about the military is they're about as close to a one system health system as you can get in the US. So we had people that were seeking care with low back pain in primary care, and ended up including 750,000 in the analysis. So this was a look over, what is it, a 2-year poll. And one of the nice things about this data set is we were able to look at people who received PT early or late and whether it was guideline adherent or not. And that was really the only exposure that we were interested in. And what do you see? What kind of pattern emerges? The reference is delayed non-adherent. And the outcomes are advanced imaging, injections, surgery, and opioid use, which are all for the spine characterized as low value care. So do you see a pattern emerging there? What's better, early or delayed? This is a decreased risk to the left. This would be increased risk, and this would be what is delayed non-adherent. So that would be considered, you know, that's the worst type of treatment, is the delayed non-adherent. It's late and it's not any good. Right? In a restaurant, that's not acceptable. In healthcare, it happens. So what pattern emerges?
Sorry, the odds ratio is increased risk of what?
Any of these, so sorry, I'll explain. So this would be advanced imaging, and this would be they receive PT. So all of these, the subset of these are all people that receive physical therapy. So this would be, they have a decreased risk of receiving advanced imaging compared to the people that had delayed non-adherent PT. The pattern we saw is it looks like it's better to be early than late, and that it didn't matter as much whether you're adherent or not, that it was probably better to get it earlier than worry too much about it being whether it's completely guideline adherent or not. Now keep in mind, this was published before the guidelines changed, where it was, this might all collapse now to be guideline adherent, because PTs, by their practice, they would be doing non-pharmacologic treatments. It would be very hard for them to do non-adherent treatment according to the new guidelines. According to the older guidelines, there were some specific things that PT used, more passive modalities that could be considered non-adherent. So this pattern suggested to us and to others, and like I said, there is converging evidence from other observational studies, that there may be some ordering to consider where the blank non-pharmacological provider is providing blank non-pharmacological options before the drugs and the care escalations. And that may be a different sequence with the medical provider. Now this sounds easy, but this is very much a challenge to, you know, the existing system, especially for systems that you need medical referral to see non-pharmacological providers because they're considered specialists. Yes.
Yeah, I mean, the frustration I have is many times I'm invited to be, you know, a person on like a grant panel or something like that, and consistently you'll say, yeah, why isn't physical therapy the first thing that these Medicare people or other providers get, or we suggest that? And the issue is always the copay. And
yep.
You know, there's no copay with drugs. There's always a copay, and so the physicians will say, well, PT's too expensive. It's better to do X, Y, or Z or whatever. And you just keep constantly showing them, well, the evidence is, you know, the downstream costs and effects of not doing,
yep.
you know, not doing PT are so much more expensive and so much worse on these individuals. It's so frustrating.
It is. It is.
Evidence over and over again.
I do know though that there's hope, because when I was involved in the work, there was a non-pharmacological workshop in DC, and David Elton, who's Optum Health, which is one of the largest providers, their data is strong enough from the observational that they're going to reverse that trend in the people they covered. And what I like about it too is, because the other thing we get in trouble too is beating the drum too loudly for PT. What they're doing is they're using a broad non-pharmacologic provider, which will include in their system acupuncture, chiropractic, and PT. So it will be a nice kind of, because I don't think there's anything specific about exposure to PT, by the way. I just think we're happen to be ensconced in most health systems where we can be the easy, you know, non-pharmacologic provider of choice. It's just that there's not as many acupuncturists or chiropractors embedded in health systems. That, you know, so that is encouraging. I agree with you. That co-payment issue came up and up again in the workshop, and one of the largest payers is going to change that. Be really interesting. And they said with their actuaries, it was a business decision. It was purely a business decision that they think they can save more money by decreasing the co-pays, and it will limit some of the care escalation things, which if you can limit a few of those, it's a whole heap of co-pays for an acupuncturist or a chiropractor. So it'll be very, very interesting to see how that evolves in different systems. So when we talk about changing the provider, there are some natural experiments available where you can look at people who come into, and notice I changed diagnosis to exam because I'm clever. But basically it's just to say that maybe we need to acknowledge that for certain people entering the health system, they don't need a diagnosis to move on to a management approach. Maybe a condition where like 99% of the time it's completely benign, and that would be musculoskeletal conditions. You know, there are 1% or so that we need to be able to identify that are serious, meaning they would need direct medical care, but the other 99%, you know, you're probably okay. So if you look at those at the same time, you can get some interesting patterns to see what happens. And this was a part, Maggie Horn at Duke, our colleague at Duke, this was a project that she led. And this is from the University of Utah's healthcare system. And just kind of a nice natural experiment, again, observational. People, if they had, this is for neck pain, people could see their primary care provider, they could see a physical therapist, they could see a chiropractor, or they could see a specialist. And this was part of just their pathway that they were piloting to see where people would go and to see what the outcomes are. And these are all 12-month outcomes. So for this analysis, the primary care provider is the reference. And not surprisingly, the specialist provider influence in the red means their increased risk. There's an increased risk that their care episode had injections, imaging, or prescribed narcotics in the next 12 months. So if you, and think of this from the patient's perspective, you finally get to the specialist, right? The specialist is who you want to see because everyone is special and everyone needs to see the specialist. And now you're in the track, and this is of receiving low value care left, right, and center. You're gonna be more likely to have injections, more likely to have imaging, and more likely to be prescribed a narcotic. The non-pharmacological provider influence was actually in this healthcare system was more consistently seen with chiropractic. So the chiropractic reduced injections and imaging and also reduced the prescribed narcotics. PTs did an okay job in prescribing narcotics, but they did not do as good a job at decreasing imaging and injections. So why do you think that is? Why are the PTs protective against narcotics, but the chiropractic care is protective against everything that is indicative of low value care, except for x-rays? Any thoughts on that?
They more naturopathic and holistic, like vitamins and
I think,
diet.
you know, I imagine some of them are. Obviously, we can't get quite down to that granularity. There were some differences. Remember, this is self-selecting. There were some differences in people who self-select to go to chiropractor. I also think, as we've been thinking about this, I also think part of this is, as I mentioned, PTs are embedded in healthcare systems. Part of this is, in some of these cases, it might be hard to get out of that network. So if PT is part of a normal medical referral pathway, if someone isn't doing better, they're more likely still to get imaging. And I think when the chiropractor, even in healthcare systems, tends to operate on a little bit of an island, and it may be harder for them to be involved with some of the injections and imaging. We don't know the answer to that for sure, but this was an interesting look because of the ability to look across specialty primary care and then two different non-pharmacologic providers. So any questions on that? And these, you know, the caveat with all of these is these are observational data. So depending on how you feel about observational data, I just wasted all your time, or it was a good indication of real world evidence. But that is, you know, the major limitation. You can imagine the logistic hurdles of doing a trial where you randomize people to get primary care specialist or DC or PT. You know, that's going to be one. Kelly will lead that one. You ready for that?
Yeah, if you do it, I'll help.
So the last thing is to get much better at predicting treatment response instead of estimating treatment effects. And the challenge with this, as I just mentioned, we covet explanatory trials. This is something I taught for 15 years when I was in the classroom a lot, you know, this evidence hierarchy, and it is, obviously, it's great. And here are the things it's great for. It's great for ensuring rigor. definitely, you know, the further up the chain, the pyramid you go there, you know, bias is not as big of an issue, and you're going to get more reliable treatment effects the further you go up. However, it's not so great for accounting for cost. Until recently, a lot of trials were done without any companion cost analyses. The people, it's really, really frustrating if you've done trials or if you read trials in the consort diagram. I always like to look at the number they screened versus randomized. You know, at best, you know, it's 2 to 1. At worst, it's, you know, you've seen some horrible ratios, like 1 out of every 11 patients were enrolled in this trial. Great. That's, you know, that's a very selective sample. And then there are some troubles because it is estimating an average effect. What do I do with the person in front of me? Is this the average person? You know, how do I use that to drive decision making? So the end result, and this is pointed out in many different sources, this is the one I took, is, you know, basically explanatory studies. I like that middle bullet. They summarize the average effects at the expense of which patients actually benefit. This is not a problem if you operate in a low variability system, but pain is a high variability system. This is a big problem because the average is the middle, but it's not necessarily a narrow distribution. It's a wide, flat distribution. So this is the opportunity to prepare for precision medicine in musculoskeletal pain. And I think it's going to look a little bit different, and I'll try to highlight that. But for those of you who aren't familiar with that moniker, here it is. I imagine everyone is familiar with this and maybe even sick of it. So we'll move on. But I do think this is where a lot of things are pushing. My concern is for a lot of conditions that have low variability, precision medicine will mean one thing. For other conditions that are more behavioral and have a lot of variability, I think precision medicine is going to be very different. Does anyone know what this is? So this is the NL Central playoff odds from 2016. I'm a Pirates fan, so you can see about where my hope diminished. It was about here. Often it's here with the Pirates, I will admit that, but mathematically they have a chance. And there was one team that had a great, you know, run, and that was the Cubs, unfortunately. But what do you think about this particular system? Does this look like it was an outcome that was easy to predict or hard to predict? Well, what is there pretty clear?
No, I guess the Cubs were doing great at the very start, weren't they?
Yeah, so this is pretty easy to predict, right? There was some, I think the Cardinals, they made a charge there at the end, but they fell short. Now compare that to this. Is this one relative to the other one?
That one's much more.
Yes, so this one is a more, you know, there's more uncertainty in this outcome prediction. So then, you know, my question is, you know, can healthcare providers offer this level of sophistication for predicting patient outcomes? What do you think? I have my answer. It's on the slide. I can't change it. But what do you think? I'm leading you to what I'm hoping you'll drink, but, you know, I can't change it if you don't. You want to see what I said first? No way, right? That's one of my huge frustrations is we have such sophistication to estimate who's going to be in the playoffs in baseball and football, and we don't offer that same sophistication in healthcare encounters. So this obviously is a model that is influential. So how is it going to be portrayed in healthcare? For those of you who saw the movie or read the book, this is the conflict, right? And it was, for those of us who work in clinical and research, I'm sure this is an eternal struggle, right? These are the people who've been doing it for a long time. They have their methods. We know how to recognize a good ball player. And then you have Lisa Simpson over here who's plugging away, and she says, well, this is what a good ball player looks like. And these two, you know, in the movie, this was a conflict. These guys know what a good ball player is, and this person has some new insights. And guess how accepting they were? Not very accepting until recently, right? The Moneyball is all about being the first team that had financial incentive to do this. and it has definitely influenced the industry. And we have the same conflict in healthcare. Here we have the clinicians. I'm a PT, so I chose PT examples. I know who has good rehab potential. And then again, we have Lisa Simpson cranking away over here, who's going to provide me some data on who she thinks is a good rehab potential. And guess what? There's going to be the same conflict, right? We see this in some of the early screening tools that we do. And, you know, why do I need that? Why do I need that? I know who's not going to get better. And it's like, no, you don't. But, you know, so we're going to have to work through that again. Why do you think baseball is so far ahead of this in this area? Money. But what else? You can have all the money in the world, right? What else do they have? Data. And this is it, right? You have to have, being a researcher, you have to have a realization when you were a nerd. And I think I realized in retrospect when it was obvious, when I loved looking at the baseball encyclopedia. When I was a sophomore in high school, you know, what do you want for Christmas? I want the baseball encyclopedia. And I loved looking through it. So it has a record of every game played through the history of baseball. That is their culture, right? They've kept that. So then when you get to prediction modeling, guess what? You have all the material there. Baseball also has some huge advantages, right? The distances and the system stays the same over all that time. I think healthcare, it's a lot more complicated because each system is a little bit different. They don't have 90 feet bases. And even though they tell you they do, they really don't. But we're entering that era with the electronic health record. We are soon going to have the baseball encyclopedia for healthcare encounters. It may take 5 years, it may take 50 years, but people are working towards, we will have more enriched data sources for what healthcare encounters look like. Problem we have as pain researchers is they're not, and here's in the interest of time, these are all the wonderful things you can do in the EHR theoretically. Theoretically is a key part of that. But what we're finding with pain research is it's really driven for administrative capabilities. And I don't think that's anything earth-shattering. But when you, again, when you want to account for individual variability and you need a few key indicators, the EHR it's very enticing, but it's also very frustrating. That's one of the things we're trying to work at Duke Health, is get a few things into the EHR that we think can help better characterize people. A little different model than Bill's doing. So here's a great example. This is the pickup tool. It's a tool that was published in Australia. It's been validated with 5 questions. It will provide an estimate of whether you're going to have chronic back pain with reasonable accuracy. Remember, the other thing with prediction and analytics is you're not getting a yes or no, you're getting a percentage of what an outcome is. All of those playoff probabilities, they were percentages. It didn't say in April the Cubs would win. It said in April the Cubs have a 98% chance. How many of these questions are routinely in EHRs so that I could go to Duke Health or UNC and say, give me these, and I want to see how many people in your system have a high probability of chronic pain, and I want to see what their treatment pathways are, and I want to see which of those got non-pharmacological care first, and I want to see which one of those had surgery, and I want to see which one of those had good outcomes. How many of those are in there routinely? Yeah, 0 is a good estimate. Some people like to argue that people measure depression routinely and that's in the EHR, and I think it is, but I don't think it's, I think if we pulled that, the missing data on that would be all over the place. And some people try to argue with me that we should be able to have, like, whether they have leg pain or in there in the record. But again, it's not going to be easily exported. So what that means is we're missing the opportunities, and I like to use weather because they're also another area that has done prediction. We're really missing these golden opportunities to see how some of these prediction tools perform in different health systems. And the power of prediction and weather is not that someone found one model that beats them all. What they can do is we have competing models, they're well known, they're transparent what their variables are. And you can see, you know, living in Florida, I can see when I need to think about evacuating, or I can see, and what really drives the model, the decision making, is the convergence, right? At some point, usually when it's too late, the models converge and everyone knows the path. But like this, I would be very interested if this were the pickup tool. What are the difference in the systems that implemented this model? Here, it looks like the pickup tool. It doesn't matter what system it's used. I know that's a little bit of a stretch, but that's really, when you think about where we use this information routinely day to day. Weather is a great example. And if you're a sports fan, if you enjoy looking at some of the analytics now that they provide, the real-time percentage of who's going to win this game is fun to look at sometimes, especially when the games change. I bet the Duke one last week, was all over the place at the end. All right, so the end is near of my talk and your patience. I always like to, she's 15-year-old. I have a 15-year-old daughter who likes to look at the comics to determine if they're really funny or not when I use them in the talk. And this one passed her muster. She thought this one was really funny. So I included it. So as I mentioned, when we revisit the last opioid, this is where I think we're going to end up with opioid prescription. Someone else is hopefully going to put as much thought and energy into the addiction problem. But for pain management, we really need to think about these systematic changes, how we can influence the system and how we can break the system of some of these bad habits that were probably precursors, at least for pain management. I think this is what we are left at, whether you're a policymaker, provider, educator, researcher. For pain management, these are the three things that I think would be really effective in helping to design new systems. So you cue the credits, right? By the way, I love the internet discussion on why Chewbacca doesn't get a medal. If you're really bored sometime, you can look at some of that. I have been very fortunate to have a strong team. Don't have all their names up there because I guess I'm selfish. But no, really wanted to acknowledge the funding sources. Have been very fortunate to have a lot of this work funded directly and indirectly through various groups. The project Kelly alluded to is this one where we're working on a large pragmatic trial in back pain, and it's kind of a unique opportunity in that the NIH is funding work to be done in the VA health system. So it from my perspective, let us bring together two strong teams that hadn't worked together to tackle this problem. And I think it's going well. We'll find out in about 4 months if we get the next 4 years of funding. And if you want to follow some of the work, we have a Twitter handle, Duke MSK, which is highlighting some of the research team that I've worked on building at Duke, at the Duke Clinical Research Institute. And it involves PT faculty and starting to work more with the emergency department and population health. So we're trying to be broad, which I know you all are already doing. So it's nice, as you know, to be in multidisciplinary environments. I think it's really, it just gives good energy and good ideas. So I'm happy to try to create a microcosm of that over at the other blue. So that is that. And there is time for a few questions, like 2 or 3 minutes. I don't know how strict you are on that, but.
I have a question. Everything you talked about almost leads to policy.
Yes.
And we work in our world of research, and now with my hat on with the Action Alliance, I do think more about how you bridge the research into policy. But who would be the groups, or where do you see moving this toward a policy?
It's a great question, and I'm kind of like, I've reluctantly understood exactly what you said, that as a researcher, I need to have a more direct pathway into policy. And honestly, that's one of the things that attracted me to Duke. The DCRI has a bridge with the Margolis Policy Center, which focuses on health policy, and they have an office in DC. So we have engaged them, and we're actually trying to, no one is quite ready to get to the next level of policy, which is, what does comprehensive pain management look like? Right now, they're all hyper-focused on the opioid prescription. So the people at Margolis I've talked to have written white papers on what are appropriate opioid prescribing parameters, but they acknowledge that, we need to be thinking about the next one. So we've started that. but it's new networks. They're used to working with FDA. For them, it's new too. They all acknowledge it's important, but it's kind of like the same thing. Their reflex is, well, I know a guy at the FDA, we can pull together this, do a symposium and write a white paper. Those bodies for this are going to be very different. And actually what I've done is I have a great colleague who's an adjunct at Duke, who's a chiropractor, and we have decided some of this messaging will be stronger coming from multiple providers. So it doesn't seem like a money grab for one particular profession. So we're thinking at the policy level, we may have to have teams that are willing to work together across different provider types. So we've thought about that. I can't give you any real concrete progress yet, but I agree with you.
Is a great first step, because it keeps it, I think if you have a major provider make a change, I mean, that's not a whole comprehensive pain management, but if you have a major provider,
yeah,
get rid of the copay, the others will follow suit.
Yep.
If they'll see, oh, this business decision works for them, they're all in it too.
Yeah.
And CMS may follow.
Right. And there was people that are much more versed in policy that were talking about that at the workshop in DC, that it will be really interesting to see what kind of the market reaction to this is. And CMS was mentioned. And so I think it'll be interesting. I know they've had a little bit of trouble in publishing the data because it's observational, but we were in a room, he threw the slides up, and it's pretty compelling, even if it's observational data. You see acupuncture, PT, or DC first, short-term opioid use way down, long-term opioid use way down. It was pretty telling. And they have a huge, I can't remember how many lives it was, but it was, it was the odds ratio, they were teeny tiny confidence intervals around those odds ratios.
And then their data is used to build value propositions for.
Yes. And that's what he did mention in phase 2. A lot of the non-pharmacological providers are not, aside from the copays, they're not reimbursed at a high enough rate to incentivize them to increase their practice. So that's the next phase, is to decide, how to make it worth your while to manage 30 people with back pain as that type of provider.
And this is much the same thing when you focus on, if you think about, when we think about an osteoarthritis action alliance, we're trying to get people into evidence-based interventions that are around physical activity and,
Right.
and weight management, and those aren't reimbursed, or people aren't referring, and we're wanting to change practice styles or change systems, and but we, over and over, what we hear, it's the money you have to come in with.
Yep. Yeah, when we looked at, I think it was a NEOA and back, and I think it was the Medicare, because Trevor Lentz, another colleague, looked at that, and in osteoarthritis of the knee and back, the multimodal intervention that 98% of people had was an injection and a drug. And those are both, very highly reimbursed. So when we were kind of trying to look for multimodal patterns, and, and these are CPT codes, but the exercise was like a teeny amount, but you could bet your bottom dollar if you got 2 treatments. One of them was an injection and the other one was a drug. And that was kind of the highest multimodal subgroup, so high that we thought, there's not even enough variability really to get into it.
For those of us who might be skeptical about chiropractic
Mm-hmm.
care, have there been newer studies to show that it actually benefits people with low back pain? Because I remember the earlier studies that were published, including like New England Journal of Medicine and things like that, didn't really show any benefit chiropractic care.
Right. And that,
say PT or just watch and wait.
And I think it's the one that I'm thinking of that was like a pamphlet compared to a pamphlet. And I think what has happened is a lot of the studies don't necessarily look at chiropractic care. They look at the modality spinal manipulation, which is most frequently delivered by chiropractors. And people who study spinal manipulations may be chiropractors, they may be PTs. Both professions contribute heavily to that body of literature. And there are enough studies that spinal manipulation has short-term benefits that are small, and it depends on what the comparator is. But your question about chiropractic care being safe, most of those have been answered enough that some of the old kind of wives' tales about arteries being torn and
Yeah, no,
things
I
have
wasn't
been,
worried about the safety.
yeah, but I mean, as a PT, I can tell you it's just as effective as, if I read the data, it's hard to say what is the superior provider. There may be some modalities that look a little bit better that both providers can deliver. And that's why, you know, in working with Christine, who's a chiropractic colleague, we've kind of just decided we need to push this non-pharmacological agenda, because we want these things to be available to patients, and then let the provider practice everything, decide who can deliver them. But right now it's so basic. Let's just get people so that their frontline access. I would love it if the frontline discussion is, do you want spinal manipulation, yoga, acupuncture, massage for your first line treatment? That would be a great discussion. The system can't deliver that at scale right now. But it's a very, very good question. Yeah, thank you.